All right, folks, we're going to go ahead and get started. If you could find a seat. Fantastic. Thank you. Thank you all. Thank you so much for being here. My name is Sarah Dash, and I am President and CEO of the Alliance for Health Policy. And for those of you who were with us back in April for our first summit on the future of healthcare, you know that we have recently changed our name from the Alliance for Health Reform, and we're really excited to be here with you as the Alliance for Health Policy, here to talk about important policy issues that we all face every single day in our jobs and in our lives. Welcome today. For those of you who know us, for 25 years, we have been a trusted source of nonpartisan health policy information and convening for health policy leaders and the health policy community here in Washington, D.C., and beyond the Beltway as well. And we're excited to bring to you today the second in our summit series on the future of healthcare. This one is, as you all know, is on the future of chronic care. A really important bipartisan topic with bipartisan action happening in both the House and the Senate. And we decided to do this series in particular because we really wanted to take a look at the important issues that are facing the country now and into the future. And of course, it's been an action-packed month on healthcare, but the issues that face people who have chronic conditions, those who are healthy but may eventually get a chronic condition, those issues are not going away, and those are the issues that we all have the opportunity to shape here today. So I really want to thank our sponsors for this series. First of all, our annual sponsors who are sponsoring not just the Chronic Care Summit, but also our Summit on the Future of Health Insurance, which we held earlier in the spring, and the Summit on the Healthcare Workforce, which we will organize later in the fall. Anthem, Ascension, and Health is Primary. Thank you all. And I also want to thank the sponsors of today's summit, CAPG, DaVita, Genentech, and Express Scripts. So we couldn't do it without your support. Let me, before I turn it over to, before we get started on today's agenda, which is going to be a full agenda, we're going to talk about the future trends in chronic care. We're going to talk about coverage issues in chronic care, and then we're going to also talk about the best way to deliver care through integrated care delivery and what that means. I'm going to turn it over to Liz Hall from Anthem, and then to Mark Hayes from Ascension, and then to Kristen Thistle from Health is Primary to just give a few brief opening comments before we get started with our first panel. Thanks.
Thank you, Sarah. We really at Anthem do want to thank the Alliance and congratulate them for 25 awesome years of really, as she said, digging in and providing all perspectives on really important issues, including the one that we're going to discuss today. I also want to thank you all for coming out, for being interested in this topic, for wanting to dig in and take it to the next level. At Anthem, we have been partnering with providers to really do all that we can to improve care for our members, to provide high quality, affordable coverage. And we really do think that by working with both providers and our patients and members, that we can continue to improve and do a better job, particularly for those who have chronic needs. I want to thank everyone, the panelists in particular, for the insights that they're going to offer today. We are constantly working to improve and innovate, and we will take away the best nuggets that we can and try to build those into our programs and services. Thank you so much.
Thank you, Liz.
Good morning, everyone. I'll be very brief. I just want to welcome everyone. Ascension is very proud to be a sponsor of this. Ascension is, if you don't know about us already, we're a nonprofit Catholic health system. We're in 22 states. We have about 141 hospitals throughout the country. We are very, very proud to be a sponsor of this. I mean, how many years have we all been talking about how the key to lowering healthcare spending is managing chronic disease better? And we've all been working on it. Caregivers on the front lines have been working on this for years, but finally the payment systems are catching up to enable this to really happen. So we're really excited about the discussions that are going to happen this morning and what we are all going to learn from our experts and the expert panel. So thank you all for being here.
Thank you, Mark. Kirsten Thistle.
Good morning. I'm Kirsten Thistle, and like the others, I'm thrilled to see everyone here today. I know some of us are sick of talking about healthcare, but I'm excited that we have today to dig in and talk about important issues around chronic disease. Just a show of hands, how many people have heard of the Health is Primary campaign? All right, not bad. The campaign is run by, is sponsored by the 8 family medicine organizations in the U.S., most notably the American Academy of Family Physicians. And really the goal is to showcase innovation and transformation in primary care delivery, much of which is happening with companies like Anthem. We believe that a strong primary care system in America can deliver on the triple aim, and I think we've seen time and time again studies that show the more primary care providers, the better the health outcomes for the community, and frankly, the lower the costs. A study came out a few months ago that showed that for every $1 spent on primary care, we can save $13 in downstream costs. So this isn't just about improving health, it's really about showcasing the biggest, bang for our buck in healthcare. And certainly, I think chronic disease management is a place where having a strong primary care infrastructure can deliver huge dividends on the back end. So again, thanks for coming out and being willing to continue talking about healthcare after a crazy couple months in Washington. And we're excited to hear from the panelists today. Thanks, Sarah.
Thanks, Kristen. So I'm going to ask our first panel to come up to the stage now, and as they're coming up, I'll go ahead and introduce them. This first panel is going to be on the trends in chronic care that we're facing in our country. So we're really excited. We have a fantastic panel with us today. John Romley, who is an associate professor at the Schaeffer Center for Health Policy and Economics at the University of Southern California. Welcome, John. Dr. Clay Marsh, who is vice president and executive dean for health sciences at West Virginia University. I know I'm not as good as like the baseball teams or the basketball teams. We don't have music for you or anything, but we're thrilled you're here. Sue Nelson, who's vice president for federal advocacy at the American Heart Association, and Peter Fise, senior policy analyst at the Bipartisan Policy Center, which has been doing a lot of work on this issue. So thank you all, and then I am going to come and join you to moderate the panel. All right. Awesome. Fantastic. Well, thank you all so much for being here. So as I said, we're here to talk about future trends in chronic care, but let's, as Mark alluded to, obviously, we've been talking about this issue for a very long time now. We've been talking about the need to prevent and better manage chronic conditions. So what I would like to ask each of you to do is kind of give us a sense of what is the country facing as we look into the future? 25 years into the future, what kinds of trends can we expect, and what are some of the issues that we need to be looking at as policymakers and people who advise and influence policymakers? And I'm going to go ahead and just ask you to go down the line, if you would, and start with John Romley from USC.
Hi, so thanks, Sarah, and thanks to the Alliance for Health Policy for the opportunity to participate today, and thanks to all of you for coming. So as Sarah noted, I'm in the Saul Price School of Public Policy at the University of Southern California, and also a senior fellow at USC's Schaeffer Center for Health Policy and Economics. And at the Schaeffer Center, we have developed a tool called the Future Elderly Model, which we use to analyze trends in population health and health spending and how public policy and medical innovation and other factors impact those trends. And so with the Medicare program recently turning 50 years old, we use that future elderly model to assess where the program is headed. So the sort of demographics are fairly straightforward. We're going to see a big increase in the number of Medicare beneficiaries with the baby boomer generation retiring. Like our society, the program's becoming more diverse, right? So the share of Latino beneficiaries is going to more than double. And the population is also becoming more educated. So the folks with less than a high school degree, that proportion falls by more than a half. So that's kind of what's going on in terms of what we expect to happen, what we project in terms of the simple demographics. Now, in terms of what's going on with health, we see some good news and some bad news. So the good news is that certain health behaviors like smoking are going to continue to decrease. But the bad news is that other risk factors like obesity are likely to increase. So we expect between 2010 and 2030, the proportion of Medicare beneficiaries who are obese to grow by more than 50%, and the proportion who are extremely obese with a body mass index in excess of 40 to more than double. And so risk factors like obesity contribute to chronic disease, of course. And so the burden of chronic disease is going to increase. Diabetes will go up from, the prevalence of diabetes in the Medicare population is going to increase from 25% to 40%. We're going to see a similar increase in the proportion of beneficiaries with multiple chronic conditions. Now, all of that, in terms of life expectancy, actually, we've been pretty successful in helping people to live longer, notwithstanding some of these challenges. And so we think that for men, life expectancy at age 65 is going to increase by half a year between 2010 and 2030 to a little more than 18 years, and for women by almost a year to almost 23 years. So all of these trends have pretty predictable consequences for the federal budget, right? So living longer, more folks, more chronic disease, and healthcare spending growth has its consequences. We used the future elderly model, though, to quantify the magnitude of those impacts. And so what we see is that lifetime spending on Medicare for someone in 2010 would be about $130,000, and by 2030 would be about $230,000. And total spending with the growth in the population grows even faster, more than doubling. So these numbers are sort of roughly in line with what CBO thinks, and that's sort of I think, the big challenge that we face. I don't think it's an unrecognized challenge, but in my view, it's probably one that can't be emphasized enough.
Thanks, John. Clay.
Well, hello, Sarah, and it's great to be here. I'm going to take a bit of a different tack, and I'll try to be succinct. But I, like the other panelists, understand that in general, we are increasing healthcare spending at a rate that's not sustainable. We spend almost twice as much as the next leading country, and we have outcomes that are among the worst in all westernized countries, in fact, next to last. And so when we look at our future in our current system, it doesn't look so bright. And I think from a healthcare delivery standpoint, and that's part of what I do, you know, our purpose and our business model have gone different directions. Our business model is rescue from failure. The more stuff we do to you when you're sick, the more money we make. But the purpose model is to help you live well, is to help you be healthy. And as I have thought myself, and I could go through how I got there, which is not quite a straight line, but when you start to say that the only way really to save money and improve outcomes in healthcare is to have a healthier population, the question is, what is health? And I don't think that's such an easy question to answer. And to me, my own bias is that health is where your biological age is less than your chronological age, where your real age is less than your birthday age. And I think that we have a country that's getting older younger, as opposed to a country that's getting younger older. And when you start to look at the things that affect your biological age, then we realize from longevity studies such as the Harvard Grant study or the longevity study, which followed people 7, 8 decades, or from the Blue Zones, which is Dan Buettner's work, where they look at people that live long and well in 5 areas of the world, so overeating is certainly one. The only way you can increase survival across animals is calorie restriction. And so obesity might be a form for us of early biological aging, accelerated biological aging. When people lose weight, you say, hey, you look younger. Maybe you are younger, so we're interested in that. And the other one is smoking. Cigarette smoking absolutely increases your biological age. That's been proven. So policies that reduce simple sugars, which drive insulin receptor, which drives obesity, and also, by the way, drives addiction centers in our brains like opioids do, is probably important. And we know that taxes on cigarettes do reduce smoking consumption, which actually probably also improve biological age. But the other stuff that you find is really interesting, and it's really human. It's not so technical. You know, it's interesting that the things that really are resonant from these long studies are people who have great connections to other people, have a great sense of purpose, and who see the world as abundant, who see the world with gratitude and with hope. And also the mindset that you bring is important, as it was shown by Elizabeth Blackburn, who won the Nobel Prize, that if you are stressed and you feel stressed, no matter what your real stress is or isn't, then you age faster than if you don't. So how we see the world influences our biological age, and she measured telomeres to be able to know that. So I think that in our world of separateness, of breakdown in communities, you know, Tom Friedman said that the difference in the country is not the coast versus the middle or rich people versus poor people, it's weak communities versus versus strong communities. And so we know that there's a term that was created by Robin Dunbar, who's an anthropologist, called Dunbar's number, which is 150, which is about the maximum number of people that you can know very well, because 150 was about the maximum size of a community you could have survived with. Big enough to protect each other, small enough to feed each other. So I think we're stuck in this evolutionary frame, but our world is really changing. Our communities are breaking down. Sam Quinones, who wrote a great book called Dreamland, came and talked and said he thinks the opioid problem is really a problem of isolation, that we've broken down the connections that matter with each other. And we know that the frame of the social network is really important. You're more likely to be obese if your best friend's obese than if your first-degree family member's obese. So I think that a lot of the policy work that needs to be done is starting to understand that really re-knitting communities together and starting to connect with each other to help people have purpose, which to me is oftentimes jobs, which in our state is really quite an issue. The last thing I will say is that Ann Case and Angus Deaton won Nobel Prize in 14 or 15 in population economics, found there's a group of less educated white people that were dying at a rate that's been unprecedented since the peak of the AIDS epidemic, 50 years old, high school education or less, and initially said they were dying of overdose and suicide and liver disease, all addiction-related problems. Recently, there's a deeper dive taken, and it turns out they're really dying of despair and hopelessness because their life used to be better and now it's not. And so as we look at this population, it's interesting that other demographic groups, other underrepresented minorities like blacks and Latinos are not dying at a rate that's any different than before. In fact, they're living better. And the reason why is the presumption is that a lot of the people in this less educated white population have seen their lives step down. So they were here and now they're here. And so our perception of our own status and the place that we have in our society becomes really important too. So I personally believe that the really important work in healthcare is the same really important work in community building and in trying to regain this sense as we had when we grew up, that the American dream was accessible to all of us. I grew up in a very middle-class household in West Virginia with my grandfather and uncle, both coal miners, but I think that that is lost on many people today. So.
Thank you, Clay. Sue.
I have to say, every time I stress, I do think about my telomeres. What woman wants to age, right? It's like, stop doing that, Sue. So I'm going to go back a little bit to the demographics. I spent 20 years on the Senate Budget Committee, and my apologies to those of you who knew me back then, who I said, no, you can't do that too. And when I joined the American Heart Association, the first thing I said was, where are your long-term projections of the cost, prevalence of various forms of cardiovascular disease? And they looked at me like I had a hole in my head because, you know, they were academic researchers and they deal with real data. But I persevered and worked with the Research Triangle Institute to develop a model that would project, again, the costs and prevalence of several forms of cardiovascular disease: high blood pressure, coronary heart disease, congestive heart failure, stroke, AFib, and then the other category. We continued to be amazed by the results of those projections. We ran them first in 2011 and more recently in January, which is why this is our report in case anyone wants to go to our website. But and substantiated a lot of the trends that were mentioned earlier. Cardiovascular disease has been the leading killer of Americans for many, many years. It's also the most costly disease, but we're also considered the success story. When Francis Collins talks about NIH research, it's look at what we've done for cardiovascular disease. There's been a 70% reduction in the death rate over the last century. And my father sort of illustrates that point. My grandfather died at 49 because he had a heart valve problem. There was no open heart surgery. They gave him morphine. That was the only treatment for heart disease back then. We forget that. My dad, with the same problem, lived to be 92 years old. So that, to me, that's the cardiovascular success story. But we still are the #1 and most costly disease. And as noted earlier, our progress in reducing mortality and morbidity from heart disease has slowed recently, not so much due to the demographics, which were always factored into our calculations, but due to the rise in obesity, diabetes, all the things that were articulated earlier. So when we did our projections more recently, we found that by 2035, nearly 45% of the population would have some form of cardiovascular disease. And the cost of that is astronomical. The cost in 2015, annual cost of cardiovascular disease, both the direct medical costs and then indirect costs and lost productivity, is $555 billion. By 2035, it'll be $1.1 trillion a year. Men tend to be at higher risk for cardiovascular disease, but heart disease is now the #1 killer of women. We're catching up, ladies. It's also exacts a disproportionate toll on racial and other minority groups, accounting for nearly 40% of the disparity in deaths in that population. And more relevant to this population, we're seeing the cost shift to the old, to people who are over the age of 65. And in terms of chronic disease, stroke and heart failure were the most expensive chronic conditions in the Medicare program. So given these developments, what does our association do about it? We have a very aggressive goal of improving the cardiovascular health of all Americans by 20% by 2020. Not sure we're going to meet that goal because of what I mentioned earlier, but we're focused on 4 different areas. #1, federal research. Only 5% of the NIH budget goes for cardiovascular research. You know, we're not the scary disease. You fund what you fear, right? Everyone's worried about Alzheimer's, and I understand that. There are no effective treatments. Certain sorts of cancer, no effective treatments. A member of Congress has a heart attack, 3 days later he's back on, the House or Senate floor. It's like people think of it as not being, as scary and deadly as it used to be. So we really advocate for more research, particularly in the area of prevention. Cardiovascular disease is 80% preventable. If you just do all the things the American Heart Association tells you to do, you can live a very long, healthy life in most cases. Obviously, there's exceptions, and genetic research is starting to shine a spotlight on why people like Bob Harper, who attended our lobby day 2 weeks ago and who is the fitness guru for America's Biggest Loser, suffered from sudden cardiac arrest at the age of 40. Why? And those are the kinds of things research can still shine a light on, but in the main, it's prevention. It's people who aren't monitoring their blood pressure, their cholesterol, they're not exercising, they're not eating right. Nutrition's about 80% of the obesity problem. Don't think that 1 hour at the gym is going to do it. I used to think that. It's not going to work. It's your diet. 80% of it is what you're eating, and the rest is exercise. So we focus on, first of all, advocating for research. We focus on prevention in a variety of areas, which I can get into later. Access to care is critical, and that's why we were working very hard to preserve the elements of the Affordable Care Act that have been so helpful for our population. First dollar coverage for preventive benefits really, really helps. We did a study recently, or a study was done recently, that found that the incidence of sudden cardiac arrest in a district or a part of Oregon declined by like 37% for people who had insurance coverage. Mortality rates are much higher among people from cardiovascular disease who don't have coverage. Almost twice the chance of dying from a stroke, because when you feeling the symptoms, you don't want to pay for the ambulance. You just take an aspirin or something else and hope that it goes away. And then a final area that we're focused on is delivery system reform. Areas like cardiac rehab, which are so helpful to people, are tremendously underutilized. Only 30% of the population really takes advantage of this important benefit. And there's ways that we can address that through delivery system reforms, but we can get into that later.
Thank you, Sue. Peter.
Thanks, Sarah. As Sarah mentioned, I'm Peter Fise from the Bipartisan Policy Center, and I want to thank the Alliance for having this event. I think it's a critically important topic, not only for ensuring smarter spending in our federal health insurance programs, but better outcomes and better quality of life for patients and their families. So just a quick word of background on BPC before diving in. The Bipartisan Policy Center's Health Project is co-chaired by former Senate Majority Leaders Tom Daschle and Bill Frist. And our work in the long-term care space is also co-chaired by former Secretary of HHS Tommy Thompson and former OMB and CBO Director Alice Rivlin. Our work has primarily focused on chronic care and long-term care issues of late, although we are also involved in a separate initiative in looking at Medicaid policy reforms, as well as policies to stabilize the individual market. But for today's topic, over the past 18 months, BPC has produced 5 reports that relate to this issue in the areas of integrating care for dual eligible beneficiaries, those who are eligible for both Medicare and Medicaid, Medicare chronic care, and long-term care financing. I'll focus today's discussion on the Medicare chronic care piece, but maybe we can get into some of the others during the discussion. So when we looked at this issue, we focused on beneficiaries who were not dually eligible for Medicaid, so they are Medicare only, and had 3 or more chronic conditions and functional or cognitive impairment. And we chose this population because the intersection between chronic conditions and functional and cognitive impairment is a pretty good predictor of poor health outcomes and high Medicare spending. These beneficiaries, the average Medicare spend for them is about twice the national average at $30,000 a year. And they tend to have higher readmissions and more ED visits, even when you risk adjust. So the question then becomes, what are they lacking? And I think one of the key ingredients is non-Medicare covered social supports and services. For these beneficiaries who look in a lot of ways like dual eligible individuals, they have similar service intensity or service use intensity and similar outcomes, similar needs for assistance with activities of daily living. The difference is they don't have necessarily the same access to those services because a lot of those services are covered under Medicaid. They're not covered under Medicare. So I think when we looked at this population, it's about 7% of Medicare beneficiaries, roughly 3.6 million, of which 3 million are in fee-for-service and 600,000 are in Medicare Advantage. We looked at ways that we can improve the integration of social supports and services that aren't covered under Medicare, so we can use that Medicare dollar better. And the primary examples are Medicare Advantage plans and accountable care organizations because they're taking risk for the cost of care of the population. They're going to have probably the best incentives to integrate non-Medicare covered supports because they know that those supports can reduce hospitalizations and reduce ED visits and readmissions, all the type of outcomes that you're looking to improve upon. When we talk about these types of supports, it can really run the range of a number of different supports as long as they are part of a person-centered care plan and are designed to improve or maintain functional status. But what we looked at closely were in-home meal delivery for low sugar and low sodium meals for like folks with congestive heart failure or diabetes. That meal can help them not have an adverse event and stay out of the hospital. We looked at supports like non-emergent medical transportation, so transportation to a doctor's appointment, or minor home modifications that can put in that, that handrail to prevent a fall in the home, or targeted case management. All of these services and supports aren't covered under Medicare, but have the ability to reduce hospitalizations and reduce ED visits. So, the good news, I think, is that in our report, we developed some policy options for Congress to consider that can help integrate these supports in both MA and in ACOs and other provider-based organizations that are taking on risk for the cost of a beneficiary's care. Among other things, CMS could establish quality measures that reward Medicare Advantage plans and reward ACOs for integrating these supports into their models. And CMS could look at waiving the so-called uniform benefit requirement to allow Medicare Advantage plans to target these types of supports to the specific beneficiaries that are high need, and not have to provide necessarily the support to everyone in their enrollee population through supplemental benefits. And for the latter point, we found that a Medicare Advantage plan could offer in-home meal delivery, non-emergent medical transportation, minor home modifications, and targeted case management, and finance that through only a 4 to 6% reduction in the existing Medicare Advantage supplemental benefits that are offered to all enrollees. So by having that ability to target, you can get a lot better bang for your buck as a plan, and we think that there are similar incentives that could be placed for ACOs and providers that are doing this on the hospital and physician side.
Thank you. And I think, we will definitely be getting to some of those issues in the integrated care panel. But I want to pick up on this issue that you raised, Peter, and Clay, that you raised, and that really kind of fits in with all of your comments around this idea that preventing and, improving the care of for people who have chronic conditions, it involves more than just healthcare, and it's beyond healthcare. It's the stress, it's the community, it's the, Peter, you kind of went into like how we might consider paying for some of these issues, right? But I'm wondering if we can go into, and since we have some budget experts on the panel too, we talk about oftentimes kind of the cost of programs in silos. So, in-home meal delivery is kind of one line item in the budget. The housing and urban development budget is separate, completely separate. I'm not sure if the health LAs and the housing LAs oftentimes get a chance to sit down and talk about kind of the synergies that might exist between their two issue portfolios. So let's talk about kind of how do you translate what, Clay, I think you're raising is kind of the root of some of the challenges with, chronic disease, as kind of the need for stronger communities, better social, intersections. I know we've seen studies on social isolation and Medicare beneficiaries as well being an issue. How should are we looking at this in a holistic enough way in a policy context? And if we're not, how do we start to get there?
Let me maybe start, and then I'll, again, try to be brief. So let me initially reference an article that Atul Gawande wrote that was really kind of a game changer. It was an article called Hotspotting, or Hotspotters. It was in the New Yorker, and it told this story about an ER physician named Brenner who basically started to look at his community and tried to identify the hot spots in his community, like crime prevention did. So the idea, if you could identify the really expensive parts of your feeder system, then you may be able to do something in a more targeted way. And this Pareto's principle, the 20/80 rule, the fact that in complex systems, which is all the systems we live in, a few agents or a few people spend most of the money, right? And CMS, of the top 1% of people, expensive people spend 23-24% of the dollar, the top 5%, 50%, the top 20% spend 80% of the healthcare dollar, and the bottom 50% spend only 3.5% 5% of the healthcare dollars. So the more we can push people over to the healthy group, the better. But Brenner identified 2 tenement buildings in Camden that were responsible for an overwhelming number of emergency room visits that he had, and identified one guy in one of the 2 tenement buildings that had been admitted to the hospital about 500 times over a 7-year period. And they looked at this guy, and the guy weighed 500 pounds, and he was an alcoholic, he was a cocaine user, he was diabetic, he was morbidly obese, weighed over 500 pounds, and every time he fell down, he called the squad because he couldn't get back up after he drank or did cocaine, and they come and check him, and his blood sugar would be off the wall. They bring him to the ER, and he'd get admitted over and over and over again. And Brenner, the doctor, became Brenner, the person, and started visiting the guy and found out that he'd been estranged from his family. He had been a cook and had not cooked anymore because he'd kind of given up hope. He had gone to church, and he stopped going to church, and he just reconnected him. He reconnected him to Alcoholics Anonymous, Narcotics Anonymous, got him cooking again, got him reconnected with family and church, and he lost 250 pounds and was basically not in the ER anymore. But this was not Brenner, the great diagnostician, doing all the technical stuff. This was Brenner, the connector, to really get at what Peter was saying. So I think that as we go forward, perhaps a less expensive and maybe sustainable strategy is one where we reconnect people back in their own communities. We talk with PricewaterhouseCoopers, who was doing a study in Texas, and they did this study with Walmart, and they gave out sensors to be able to measure blood sugars, et cetera, and they found out that training people from the communities to go visit people was actually their most important intervention. And so I think a lot of times we like the high-tech stuff, and in medicine, we are also very focused on precision medicine and cancer. Can we identify the cause genetically, and can we address that using targeted therapy? So I think there's certainly room for a high precision, high technology-based medicine, but the default really shouldn't be that. And when we think about healthcare and health, health is what you do in your real life. It's not about more clinics. It's not about more hospitals. It's not about more access to a doctor. It's really about more how your quality of life is in your own community. It's interesting. There's 2 studies I think are really, really powerful. One is by the Kaiser Foundation, and they did a study that they identified something called an adverse childhood experience score. And so this is basically a 10-question test you give kids 18 and under, and it asks about neglect, trauma, and family dysfunction. And basically, it asks questions like, did you feel safe when you were growing up? Did you feel loved? Did you live in a good community? Did your parents live at home? Did a parent get divorced? Did a parent get put in jail? Did you ever get threatened with violence, et cetera? If your score is 1, your risk of every chronic disease and addiction goes up. If your score is 4, then your risk of emphysema is 1,200 times greater than if your score is 0. If your score is 6, you're likely to live 20 years shorter than your peers. And if you look at J.D. Vance, who wrote Hillbilly Elegy, his score was 7. And what's the offset? The offset is resilience, is people who care about you, who love you. And for him, it was his grandmother. Sorry about those of you who haven't read the book. But basically, this idea that we need more connections, more people to provide safety, to provide love for people, right? Google did their study, their best teams versus all other teams. The only thing that differentiated their best teams was a higher degree of psychological safety. And if you think about this, Maslow's hierarchy, physiology, safety, love, self-esteem, self-actualization. And the other one is the Gallup Wellbeing Survey. So that's 5 questions asking you health, financial health, social health, community health, purpose, and your sort of the way you look at the world. And West Virginia is last for 6 or 8 years in a row, depending on which reference you look at. But the bottom line is, if you don't feel like that you have a chance, then you have problems as well. So I think that this frame of trying to reconnect people using the more holistic approach, Sarah, as you alluded to, maybe a much lower tech and a much cheaper but a more sustainable frame. But I think it's also reconfiguring how we're helping people build resilience in communities. And I think the things that help people find jobs and get education, et cetera, are really part of this frame, just like the connection to people are.
Any other panelists want to comment on that? Sue, thank you.
Well, I think my response would be, I agree, but you need somebody to do the reconnecting. It just doesn't happen. So how do you make that happen? And the more I think about health policy, the more I realize if you build it, they will come. If you provide the financial incentives, they will do it. I really should have gone to business school for this job because it's always ends up being about money. But if you look at cardiac rehab, it's a great example. There's a million reasons why people don't do it. They don't have transportation. They don't have money for the copay. They've got to take care of their granddaughter, and they can't get time off. One woman was afraid to do it because she'd never worn pants in her adult life. You know, she was very conservative, and getting on a treadmill in a dress just wasn't going to work. She got over that, and she's now a real adherent. But how do you get, so I met with a health system in Delaware, what's it called? Can't remember the name of it. Anyway, they got some money from either PCORI or CMMI. And what they did was they looked at every individual and figured out what the problem was, and they solved it. They addressed it. They had an 80% take-up rate because they just, it wasn't a one-size-fits-all solution. And that's why you can't really separate this from delivery system reform, because in the cardiac rehab bundled payment initiative, buried in there is a demo for cardiac rehab, which says to hospitals and CR programs, we'll pay you more the longer people stay in your program. We'll give you a benefit payment. You go figure out how to make that happen. We can't micromanage this. You figure out how to make it happen. Unfortunately, that's been stalled by this administration, but we're hoping it goes forward eventually.
Thanks. So let me ask, John, you alluded to some pretty staggering numbers in terms of the future of the Medicare program and the aging of the population. You talked a little bit about, some of the Medicare beneficiaries of the future are more educated, et cetera, but then we're also hearing about, these problems and challenges that, also seem related to poverty and to other issues. So what does the population look like in terms of its ability to be, connected? And, how is the Medicare program even, how do you translate these things into a program that has been very healthcare focused?
Gosh, those are tough questions, but great questions. So, we haven't looked at the degree. We haven't looked at isolation, social support, resiliency, and all of those factors in our analysis, in our future elderly model. I think it would be interesting to take a pass on that for sure. And in fact, we've just started to collaborate at our center with Angus Deaton. So, this is a direction we should head. In terms of how to do it, I don't feel particularly expert at it. One observation I would offer is, so I'm very sympathetic to what you had to say, but one observation I would offer is, somehow you have to pay for those things, and we're already, it seems to me, we have a bit of a knife fight between competing priorities right now, and probably will for the foreseeable future. So it seems to me that the leaders in this room and outside of the room need to be very creative and, I guess I would say, resilient in trying to figure out ways to create win-win situations, to broadly share the gain, because you hear these stories which are very compelling and give you hope about how we might improve, and yet we seem to struggle translating them into practice. So I think we need to be very creative, and it's above my pay grade, those decisions. Yeah, I'll stop there.
Thank you.
Can I just make one real quick comment? I think that one of the real challenges, and I think that you made a very smart comment, but is the healthcare delivery sector has to be part of this solution. So the problem is we're making a ton of money. A ton of money. So our system's working exactly the way our system's designed to work, which is do a lot of stuff to people that are really sick. And that's, heart hospitals, cancer hospitals. And I think that the key is that we need to start taking responsibility for our population. And the only way that you can connect the business and the purpose end, I think, to get to the point, is that you have to take risks for your population. And you have to then own the whole lifespan of these people's experience, because then it is to our financial benefit at a business level that meets our purpose, which is to help people stay healthy, because then if people don't spend as much money, that's resources that we can reinvest in better stuff. And I'm hoping that we can do this as a collaborative with our entire state, because we only have 1.8 million people. And so to me, that would be a grand experiment, because we spent almost $5 billion last year in West Virginia for 1.8 billion people, and we have still among the worst healthcare outcomes in the country. So you got to believe there's something better that we could do at a lower price that could then reinvest back in education and jobs and hope.
Yeah, and I think that investment from providers and plans, on the acute care side is really important, because we know that 70% of adults age 65 and older are going to need LTSS at some point in their life, and about half of them will have sustained need of over 2 years. That dynamic isn't going to go away, but you're going to have Medicare beneficiaries who may be 65 now, in large groups going and aging, and once you get to about age 80, your LTSS need becomes much more significant, and so that we need to think about smarter ways, whether it's through the Medicare dollars or elsewhere, to engage health systems in this process.
Thanks. And so I want to pick up on something, and then we'll open it up to a couple of questions from the audience. But you mentioned LTSS, long-term services and supports, and we, as we know in this country, or most of us who follow these issues kind of are aware, we don't have really a kind of a system for really paying for long-term services and supports, other than the Medicaid program, which takes on the bulk of the financing of long-term services and supports. John, of course, you raised the cost issue of how are we going to kind of pay for people who have kind of pay for the care for chronic issues and functional limitations. So can we go into that a little bit? I mean, is this a little bit of an elephant in the room here that, again, as we look not just today, but 5, 10, 25 years into the future, that this is an issue that if it's not addressed, what can we expect as a country?
Well, the problem is the way it's being addressed is to cut Medicaid, which is not the right direction to go in. That's sort of obvious.
Yeah, I mean, Medicaid's going to be there as that has a core role. The program supports about 64% of nursing home costs. But I think that, you talk about elephants in the room, and I think one of those may be that our efforts at delivery system reform have focused a lot on moving from volume to value, and really improving the way that we pay healthcare providers. But until you make that connection, that it's not just about improving payment accuracy and bundling payments, but it's also about addressing needs of services that aren't covered, which, if unaddressed, will result in more costs, you're not really going to get at the root of the problem. And so that's, I think, a place where some redirection would be helpful.
I might also add that, so I agree. I think one of the real big challenges, too, is the way that we look at aging in our society. So, in the old days, the aged parts of the community were the wise, sort of sage people that you went to for advice. Now, nobody wants to get old, and then people are dropped into nursing homes, and we're not really, if we think about Airbnbs and we think about services like Uber and other things, taking advantage of unused capacity in our system. If you look at our retirees and our elderly, this is an incredible sort of group of assets that we are not leveraging at all. I think that having a reform in how we think about elderly care is really important. I was also really moved powerfully by Gawande's book, Being Mortal, which is the story of his dad's cancer and him as the son physician learning about palliative care and hospice, and the fact that palliative care is not sort of saying that we're done, we're giving up the fight, but more that we want to make sure that we provide love and safety and care and support. And in fact, if you look in many situations, people actually live longer and better quality. So I think that utilizing more services like palliative medicine, hospice, having a different kind of access point, because for a lot of people, when you retire, you lose your purpose, and when you lose your spouse, you lose your social network, you become isolated, which is really part of the problem. So I think that there is great opportunity as we look at long-term support services, not only to have a better path to deliver the services at a cheaper incremental cost, but also to leverage the assets that we're delivering to. Because even though people may not be mobile, using technology and telecommunications, et cetera, mentoring, facilitating, training, caring, connecting, I mean, there's many, many opportunities I think that we haven't figured out how to leverage yet.
And we've talked a lot about sort of the holistic point of view, and one thing I think it's important to emphasize here is just the scale of informal care that people provide to their family members, for the elderly, for young kids. For Alzheimer's, it's estimated that if you took the informal care that a spouse may provide to another spouse with dementia and ask what would it cost to provide it in the market, it's on the order of $80 billion a year. And so, when you cut Medicaid, and I'm not taking a position on that, but when you cut Medicaid, you're in some sense just moving that effort off the federal books, but you're not necessarily moving in improving quality and lowering costs. You're just kind of shuffling the cards in the deck somehow.
Thank you. So I'm going to open it up to a couple of questions from the audience. I see one here, and okay, and there, and there. So let me go ahead. Introduce yourself if you would, and ask your question, and then we'll have time for those questions.
Sure. I'm John Clymer with the National Forum for Heart Disease and Stroke Prevention. So you all imparted a lot of great information and lessons. To me, the most important comment made was Dr. Marsh's comment that our purpose and our business model go in different directions. And I think a lot of us see that, the corollary, I think, is Mark McClellan's mantra that, yes, we outspend every other country, and we get lower or worse outcomes, but we get exactly the care that we pay for, that the system's designed for. So my question is there a path that you all see to align incentives and knock down this system of perverse incentives that we can get to without having to roll all the people who are heavily invested in the current business model?
So I believe the answer is yes, and I mentioned it earlier, but I think that we have to start working together. I mean, part of the challenge in healthcare is we're all fighting each other at the same time. We're perhaps not providing exactly the care to facilitate driving health. One is we have to start to work together better, and I think that there are certainly financial ways to incentivize that. Two, I think that we need to be responsible for our population, and once we're responsible for our population, then it's our business model to address prediabetes the way that we address, advanced cancer today, that we would then start to help people find jobs and start to help people get educated. It's interesting that if you're a less educated Latino woman and you have a baby, the baby's telomeres are shorter than if you have a more educated Latino woman. So I think that there are opportunities for us to facilitate and help in different ways than we're doing today. But I think you make a very important point. We are a huge industry sector. In the state of West Virginia, we are the largest employer by far. And we're bigger than Walmart, which is, perhaps some not great thing to brag about, but nonetheless, in West Virginia, we are. So we would destroy an economic sector if we sort of took away everything. But I think that the idea is you still need to pay for very high-level, complex care, and that requires resources, but you need to bridge that with the opportunity to benefit financially from helping people stay well. And that means in their own communities. And I think the way you do that is you collaborate, you work as a group with the state that you're with, and eventually with the country, to say that we want to reinvest money in better quality of life for people. And the other thing for me is I'm a big subscriber of the broken windows theory as well, and I'd love to see us do that. The idea that Giuliani and Bratton, the police chief of New York City, instead of just arresting the rapists and the murderers, they fixed the broken windows, they painted the graffiti-covered walls, they took the squeegee guys off the street, they stopped people jumping the turnstiles, they recovered pride and order for their communities. And for me, I think that there's a lot to that. And if we started a big sort of internal clean up the place campaign where you made every community look like a place you would love to be and a place that looks like a place that you and your family would want to be, then I think that we could make a lot of progress on things too.
Yeah, and just to add quickly, we're going to probably cover this in a later session, but there are a number of policy levers that you could take to address this issue and improve incentives, whether it's quality measurement or risk adjustment, to better incentivize providing more holistic care to a patient that goes beyond just acute care and traditional medical services.
And I would just say that under the previous administration, there was a lot of focus on delivery system reform. It remains to be seen where this administration or Congress is going. I think they're more likely to focus on letting states take the lead on this and the private sector. So I don't know, John. I don't know where this is going to go at this point.
I think we need to hold two ideas and some tension in our mind, that we can be optimistic about these opportunities and exert ourselves mightily, and also that it may not be enough, because in my view, the scale of the challenges is just very, very large. And I think it's important to recognize that dealing with these budgetary challenges only gets harder over time, much harder.
Thank you. So there was a question over there, if the young lady still wants to ask her question, and then the gentleman here. Thank you.
Yes, my name is Yvonne Washington Teray. I'm a primary care provider, and I provide care to many of the underserved populations in this community and also around the world. So I'm hearing you talk about prevention and trying to get back to that model. But I work with a lot of people who really don't want to take care of sick people. And it's very challenging because on my panel, I get people who have chronic kidney disease, stage 4, diabetes, cancer, they're just multi-system failure. They're really messed up. And many of the medical providers I work with do not want to take care of them. So how do we get medical providers who want to stay within the system, because the government is giving incentives to doctors, nurse practitioners to work with underserved populations, but they work for as long as their loans are paid off and then they're gone. And that program is a failure. I'm here to tell you it's a failure. People like me, I've been in the system ever since I've been in medical care for over 20 years. And I have worked with underserved populations for over 20 years, but there are no incentives for people who have worked and proven that they want to care for underserved populations. So not only we have to do prevention, but we have to give more incentives for people to stay and prove that they're going to stay to take care of these populations, because they're not being cared for. The emergency rooms are still being full. I work with people who still think the emergency rooms are their primary care providers. How do we break this chain of just, I'm going to say it, it's not health care. I don't know what to call it. It's not health care. How can we fix it?
It's a great question. So how do we, and we're getting a little bit into a question about access to care via the workforce, the people who are there to provide the care in underserved communities, where there may be greater need for these kinds of social supports and things that we've been talking about. And we do have, our summit coming up on workforce. So, but can you all touch on a little bit of
What is the slogan? Health is primary. I couldn't agree more.
Yeah.
It all starts in the primary care office. You need more support, financial and otherwise. I don't know if this is an established position of the American Heart Association. My policy person is looking at me. But it all starts there. I mean, my father, when he was dying of heart failure, his best friend was his primary care doctor. His best friend. He handled everything. And at one point I said to him, don't you think we should see a heart specialist? He's like, nah. And he was right. He did an excellent job. I don't know where the supports are now, but that's where it all starts in my view.
I might also say, for folks like you who are doing great work, I'm sure out there, that it's even more our business model doesn't really support you, because
Yes.
spending time with people and caring about people, the Francis Peabody, the secret in caring for the patients, caring about the patient, is not reimbursed. It's RVUs and their technical, procedural, not cognitive sort of time spent with people. And so I think that purpose model, again, is really hard, and many people in medicine are becoming very, very unhappy with the job as currently expressed. But I think that the only way you can do that is if you own that patient and that patient's lifespan as part of your own system, then you're taking care of all those parts of that patient, because that is on you to do. And I think that when you have these parallel universes where the primary care people are separate than the specialists and different systems back and forth, people don't want to accept lower DRGs, or if you've used a DRG, they don't want to accept the patient if the person's on this payment plan versus that payment plan. And the problem is when you have all that sort of number of people coming between the doctor and the patient and what the patient needs, it becomes really, really complicated, unnecessarily so, but it starts to interfere with the delivery of care to that person, which is really your primary duty and responsibility. And I would argue it's ours too, but we've just sort of forgotten that at a delivery system.
A related issue is risk adjustment. So the National Academy of Medicine recently took up the issue of whether we should move beyond the clinical and think about the social factors. And CMS several years ago in risk adjusting mortality that's publicly reported stopped using race and ethnicity because they didn't want hospitals to be held harmless for disparities. But you could think about risk adjusting more broadly on the payment side to potentially help.
Great, thank you. So there was one more question we have time for one more question, and then we're gonna wrap up the panel. Thanks.
Thank you. I'm Doug Tynan, the Director of Integrated Care for the American Psychological Association. But I'm not gonna ask a psychology question, I'm gonna ask a technology question. Peter, you mentioned meal delivery, home modification, and transportation as essential for the aging population, but I also heard the baby boomers is more educated, more accepting of technology. What about non-medical technology? Where does self-driving cars, telemetry from home, drone delivery from Walgreens? I mean, everyone laughs, but when my father was 88, he went to assisted living because he decided he should not be driving anymore, but the driving was the only issue. If he had a self-driving car, he could have stayed in his condo for 4 more years. So do you factor these advances in technology when you're looking at the aging population?
Yeah, so I mean, I can't totally speak to self-driving cars, but I mean, I think if it helps the patient get the supports and services that they need, all the better. I don't think that we prescribe ourselves to solely, traditional forms of interventions. Telehealth comes to mind as a good example where a technological advancement can result in more regular monitoring of a patient in a home in their own home, who may otherwise have difficulty getting to the doctor. And that evaluation, management, and monitoring is able to keep them out of the hospital. And that's something where tech and touch work together. But I do think that there is, the human contact is important too. So when you talk about in-home meal delivery, it's not just that delivery of a nutritious meal that keeps the patient out of the hospital. It's also the person who's there who can look at the home and identify different falls risks or other concerns that may not be identified otherwise.
And I would just add really quickly that I think that's a really smart question, and certainly many things will change. But if you talk about telemedicine, you now are extending that to tele-echo, which is a set of programs a lot of people are doing, which stands for Extending Community Health Outcomes, which is really taking specialists and training generalists to do particular activities like opioid addiction recovery, like heart failure management. In areas where you may not have specialists, you actually can get the services that are important. And I might even argue that maybe using telepurposing or teleconnection for people that may be isolated to supplement, not replace, but supplement having people come into your house may give you the opportunity to facilitate and improve outcomes and improve quality of life for people long term.
Thank you. It's a great question, a very futuristic question. And having seen a drone actually go down the sidewalk one day, I was amazed. Maybe it's not as far away as we think it is. Great. Well, we have just a minute or so left on the panel, and I want to end on a little bit of an optimistic note and just kind of ask, looking ahead. I mean, what, if anything, gives you a sense of optimism that we can make progress on some of the challenges that we have talked about on today's panel? And I'll let that rest for a second.
So I'll just say I think there is tremendous interest and enthusiasm from both the plan and provider community in leveraging some of the supports that we talked about, both as a way to reduce readmissions that have a direct payment policy impact, but also as a way to improve the quality of life for the patients that they care for, their enrollees in their plan. And so I'm enthused by the work that's going on out there in the community.
I think someone will figure out how to make money on solving this problem. It's just like Uber, and I'm glad you brought that up. I don't think, no offense to all of us policy wonks, it's probably not going to be us. Or, I think some brilliant person out in California somewhere, wherever they are, being brilliant, is going to come up with something, like senior living to get collectively. Some of my friends are already talking about, should we buy houses together and all, help each other out? Something. Honestly, I think we can't see the solution right now, but somebody's thinking about it, and they'll come up with something.
Well, I'm optimistic because I think that many people in the provider community as well as in the payer community are very dissatisfied with the services and the expense. And I think that as I've articulated, I think a lot of the problems that we see today, opioid addiction, chronic disease, are really symptoms of the real problem, aren't really the real problem. And the real problem is the breakdown in the fiber of our evolutionary frame that we have come from not that long ago. And so I think that the answers are really much more foundational and much less difficult, perhaps hard to incorporate because that's not how we're paid today. But I think it's not only going to take great, sages like Elon Musk or Steve Jobs or somebody else, but it's going to take people that are either tired enough of doing what we do, they're going to try something different, or people that can't sustain what they're doing and will try something different. Because right now, everybody in healthcare is very, very nervous because our system is getting squeezed and squeezed and squeezed, and the idea is it's not right. And so the incentive and the pressure, all pressure goes downstream from higher to lower resistance. And so I think that many groups are starting to think about now how to modify that. So I think you're going to see a lot of disruptive innovation happen because of that.
That's a good word.
Trying to be as optimistic as I can be and also succinct, I would say that human beings have shown themselves to be very ingenious and resilient.
Yeah.
Very good.
Thank you. Well, that is a great note to end on, and we get a break. So let me first thank our panel. Thank you. Thank you. Thank you. We will come back at 10:15. When you come back, there are some empty seats. So if you are not saving a seat for somebody, if you could just make sure that seat remains empty. And we know some people need to sneak out. Don't be embarrassed. It's okay. We'd rather you find a seat. We'll be back at 10:15. Restrooms are around the corner. Thank you.
Thank you, you too.